This conference will now be recorded.
Okay. So welcome everybody. This is the high-risk recurrent advanced prostate cancer group for the 28th of July, the fourth Tuesday in the month. Starting early, 6 o'clock for those of you back east, 3 o'clock for those of us on the west side of the country. And we usually allow new people to come up first, but we've got a mystery person and we don't know if that mystery person is new or old. So one more chance. If you would like to tell us a little bit about your situation, please identify and talk to us. If not, that's perfectly okay too. And just listen in.
He just left.
They left.
He left, yeah. Too much
They
pressure.
left.
I think Scott Hogan is new also, Rick.
No, Scott Hogan is not new, or even close to new.
Sorry, Scott.
I
I need a new memory, I guess.
Yes, it must be. That docetaxel may be doing good for your PSA, but it ain't doing much for your brain cells, Jake. All right.
My
So we don't
apologies,
have
Scott.
anybody new. And right now, we only have 17 of us, which is great, given our recent records. So we should have plenty of time. What a pleasure that would be. All right, I'm going to run down and see who would like some time. Jake Hannam is top of my list, and he does want some time because he wants to tell us about how well he's doing. So you're in, Jake.
All right, thank you.
You did that without moving your lips. Okay. Len, would you like any time today?
No, thank you, sir.
Okay. Russ, would you like any time today?
Yeah, under 5 minutes.
Under 5 minutes. Okay, under 5 minutes for Russ. John Ivory, anything for you today?
Maybe 10 minutes.
Yes? Okay.
One quick question, yeah.
Okay, no problem. Jerry, would you like anything, any time today?
No, thank you. I'm fine.
Good, good. We like that. Dennis Correa, anything for you today?
No, thank you, Rick.
Paul Frieda, anything for you today? Mr. Frieda. All right, we'll come back to him. He's probably stepped away. Les, anything for you?
Not today, thank you, Rick.
Here, I'm here.
Oh, you're there. Would you like any time today, Paul?
No, I'm okay today.
Okay. Jim Ward, anything for you today?
Yes, I've got one question.
Okay. Dennis McGuire, anything for you?
Nothing new. Thanks, Rick.
Okay. Carl Forman, anything for you?
Yes.
Okay. Herbert, anything for you?
Yes, couple of minutes.
Okay. Scott, anything for you?
Just one question.
Okay.
Thank you.
John A, anything for you?
Got a question, yep.
Okay. And Joe Blanchette, anything for you?
Yes, one question, thanks.
Okay. All right, well, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 6, 7, 8, 9. We should be fine. There's 9 of us. There's 9 people that would like some time, and we have the full 2 hours. So we're an hour and 45 at this point in time, but I think we will do just fine. So I think let's get started. Let's just see. Scott is telling me that there's a lot of echo on my end. Is anyone else getting echo from me?
Not me.
No.
Whoever it was muted themselves.
Yeah, okay. Scott, when you speak, it's echoey, so it might be something to do with your mic. I don't know. And Nazir just joined us. Nazir, welcome. Would you like some time today?
I'd like to ask a few questions if I may.
You may. Okay.
Thank you.
And I'm glad you joined. Okay. Now Peter Monaco just came in.
Hello.
Hello, Peter Monaco. Would you like some time today?
No, Rick, I'm just going to listen in tonight.
Okay. All right. So, Jake, why don't you fill in the guys about your news?
Okay, thank you. For those who don't know, I'm a Gleason 8, stage 4, with numerous Mets in my spine. I've tried most of this. I've been on Lupron since 2012. I've tried almost all the second-line anti-androgens, with the exception of darolutamide, and they've all stopped working. So, as Rick kind of mentioned me in passing in his letter, I capitulated and decided to go to. I used to be an ABC guy, anything but chemo, but I capitulated, as Rick puts it, and I am now taking chemo 3 weeks on, 1 week off, because the doctor was concerned about the side effects, based on my physical being. Anyway, so after 3 weeks, my PSA went from 186, which is the highest it's ever been, down to 136. It dropped 50 points in 22 days. So I don't know if that'll continue. I hope it does. I hope it keeps on going down, but to be honest with you, I'm just thrilled to death. That's it.
Great news, Jake. Good news.
Thank you very much.
Yeah.
Congrats,
Jake.
bravo.
Thank you.
And how
How
you
are you
feeling?
feeling, Jake?
Say again?
How are you feeling?
I'm surprised, but I actually feel okay. I mean, the Lupron has kept me tired for 8 years, and the chemo doesn't help. But I had a week off last week. Tomorrow is my second round of 3 weeks on and 1 week off. So I'm feeling okay. I have one week I had diarrhea. The next week I was constipated. But as they say, all things must pass, and they finally did. So, but thanks, Les. I feel okay for the moment.
You sound good.
Thank you.
Jake, where are you? In Arizona?
No, I'm in Laurel, Maryland.
Okay, thank you.
Right down the road from me.
That's right.
Who said that?
It's Herb and I'm in Chevy Chase.
Oh, well, welcome, neighbor. Yeah, we are right down the road.
Okay, so any questions you have for the guys? The one thing I want to mention about Jake is that, as you probably picked up, he's doing a weekly chemo schedule, which is very unusual. The dose is, I think we figured it out, didn't we, Jake? It's about 30% of the normal dose.
Yeah, I think. Actually, I think it's more like 35%. So after my 3 weeks, I actually get more chemo than the average person on getting it every 3 weeks. But it's just a lower dose each time, which I guess I can tolerate better, if that makes sense.
Where are you being treated?
Right here in Laurel, I had a local oncologist.
Jake, I've never heard of that chemo regimen before. Did the doctor tell you that they have any stats on previous patients who followed that regimen?
Well, what I did, Len, is my doctor is not very communicative. I had to do my own research, but when she suggested it, I looked it up, and even though the standard of care is every 3 weeks, and then I guess 1 week off, but I look it up in the original studies back in, not the original studies, but some older studies back in 2004, showed they compared the weekly dose and they compared the 3-weekly dose, and including for other cancers, breast cancer and others, and including prostate, and they found them to be comparable.
Oh, that's great.
Yeah.
Yeah, I have heard of it before, but not very often.
Right.
I
It's not the standard of care.
No, I mean, I maybe known 2 or 3 other men over the last 12 years, 12 or 13 years that have done weekly. Most people do not. But it is a really good solution for men who feel they may respond very poorly to the docetaxel or are worried about side effects. I mean, it is. I mean, the good news is the lower dose does lessen the side effects. The bad news is that you've got to go in every week.
Right. And I think that's the main reason why but most doctors do it. The 3-week thing is more convenience for the patient than anything else. But so far, I haven't lost any hair, or at least not appreciable amounts of hair. And I haven't lost my fingernails haven't gone crazy yet or anything like that. So far the side effects are pretty minimal. We'll see how this next round goes.
Are you taking Neulasta?
No, well, okay. Neulasta is for the 3-weekly people to get it every 3 weeks. That's the patch on the arm. I get Neupogen, which is a shot. My wife gives me a shot the day after. Same beneficial effect. You know, the idea is to keep your neutrophils hopefully high enough so that you don't get febrile neutropenia or anything like that, which is a big concern. That's the biggest problem with chemo is the neutropenia. You end up in the hospital, and that's so the Neupogen is a shot, different than the 3-weekly Neulasta thing, but it works the same way.
Jake, do you have it on your list to talk to your doc about whether that loss of weight could have anything to do with the steroids?
No, I wasn't. That wasn't on my list.
So,
My loss of weight, Rick's been over 8 years. Has nothing to do with steroids. I was losing weight long before I ever got on Abby with the prednisone.
Okay.
In fact, I've been this week. I've been eating a little bit more, and I've gained a little bit of weight. I gained about a pound.
Okay.
I mean, I went from I'm 6'3", where I used to be 6'3". I probably shrunk a bit, but I was 208 at one time. Now I'm down to 159. But that was over a period of 8 years, as I said.
I thought you just had lost more weight over the last few months than before.
I'll have to go back and I keep track. I weigh myself every morning. I do keep track. I'm anal about keeping records. I'll have to go back and look, but I don't think it was anything more than usual.
Okay. All right. Anyone else have anything that they would like to address about this weekly chemo schedule with Jake?
I guess just as a reminder for us, is it docetaxel and carboplatin, or what type of chemo?
Just docetaxel, Carl.
Okay.
So I just did a quick literature search, and there is some literature on this, even with people who originally had standard every 3-week Taxol. And I mean, again, there's variability in patient response, but you seem to be a part of the patient. They've had significant responses in a good percentage of patients. So it's not an entirely novel trial.
Right. And I think it's worth everybody who does have to consider chemo bearing in mind that it is an alternative to take less chemo more often, and to discuss that with your docs, because the default is once every 3 weeks. And as we know, there are a lot of men who don't do well on the default.
Right. It's just too much at one time.
Right.
You know, I think the big thing, as well as Herb pointed out, it is they are comparable as you know as far as the efficacy. But I think the big thing is the convenience. You know, she told me come in every 3 weeks and then you get a week off, and I go, okay, I can handle that. And then she says on my 4th week, she says, oh, by the way, you got to come in and get a blood test. So, so the inconvenience of going to the doctor every week is definitely there. But you know, it is what it is. And then I'll get another blood test, I guess, in another on the 4th week, 4 weeks from last week. So,
Jake,
I'm
the
assuming they give you
standard
a
of
blood test every
Herb,
time you get chemo.
Go ahead, Herb. Herb, can you repeat that?
No, I was thinking you should get a blood test for each week you get chemo.
okay, well, let me correct that. They do in the office, they do a WBC. They have a little machine and they can check certain blood samples. The monthly thing is the PSA. She
Okay.
can't do that. She has to send that up to the lab. But they do a WBC. I think it's not WBC, CBC
But
to
they
make sure
want to
you
see, they want to make sure you're not anemic before they give you this stuff.
right, exactly. And they want to check for anemia. They want to check for neutropenia. So
Right.
the CBC is covered by that in the office. Thank you for making me clarify that, Herb. It's an important point.
Hey, Jake, are those bone meds painful or painless?
So far,
It's fine.
I've had lower back pain for years. That was one of the reasons I went to the doctor back in 2010 and then 2012 when I found out I was metastatic. But other than that, I don't really have many bone pain. I do take an oxycodone once in the evening. You know, she said I can take it up to 2 pills every 6 hours, but I've never done that. I've taken 1, maybe 2 at the most, and it does help me sleep. And if you see my video, I'm not ready for prime time today. That's why I'm not on video. But you wouldn't want to see me. I'm horrible. But if you see me, the other guys know that you'll see me on my elbow, laying on my side on the bed, because that's the most comfortable for me. If I sit at the table, you know, drinking coffee and whatever, you know, company or whatever, then I start feeling it very quickly. So that's my way of dealing with it, and so the pain is minimal, and I'm thankful to God for that.
Len?
Yeah, so first, Jake, you're always beautiful. Never mind this horrible stuff. You're always beautiful to us. But I wanted to ask you the standard of care administration of docetaxel is 6 cycles, so 18 weeks. Is that more or less the same? I mean, I know the way you get yours is different, but it is the ultimate end of the therapy 18 weeks, or they just keep you going as long as it works?
Yeah, it's early days, of course, and you know the effects of chemo are cumulative, and you know so the longer you're on it, the more likely you are to drop off. But I asked her that question, and she said we'll do it as long as it works, is the way she put it. So there's no known time frame.
Okay.
And, you know, and as far as the 3-weekly thing, you know, the standard in America is 6 weeks, but in Japan and Europe, they do sometimes 10 cycles. And Ken Anderson is, and even more than that. And Ken Anderson is another one who's on chemo every 3 weeks. And he plans to do more than just a 6. So.
Yeah. Jim Harrington was on some kind of chemo regimen for a long time. You remember, Rick?
Yeah, he was. Yeah, he was. All right, let's move along. I'm sort of keeping one eye on the time, so I want to move along.
Thank you, guys.
Pleasure. Our pleasure, Jake. It's a pleasure to get you to talk freely. We don't have to dig the information out of you. I can't tell you what a pleasure it is for us.
Well, wait. You wait till tomorrow night when I've had my shot of dexamethasone. I'll be even more loquacious.
That's right. Russ, what's on your mind?
Well, first I want to say, as far as good looks go, we set the bar pretty low in this group. So you're not exactly with beauty kings here. But I'm glad it's working. Glad the PSA is down. But for my own selfishness, then I'll talk about me. Uh, just a quick summary. I'm a 4+3 with reoccurrence. 1 year after surgery, I started 39 rounds of radiation, which I'm now through. I get my last Lupron shot day after tomorrow, and then go to my urologist to find out what's going on with my right kidney. I have a lesion. They started calling it a lesion in the beginning, but during the last year, it's doubled in size. It appears to be more fatty and not, potentially not cancer. So I find that out on Thursday. They probably want to do a CT on it again, and we'll see where that goes. But the big question I have is for the guys that were on ADT and Lupron is, has anyone else had any, well, I call it dead leg and just extremities that are just very tired? Is that common among Lupron and Casodex patients?
Yeah, it was for me, Russ. I'd get up if I sat very long. This is when I first started the regimens. Sat very long, or I got out of bed in the morning, my legs would feel like two telephone poles.
Okay.
And I'd have to get up and I'd have to stand there for 30 seconds or so before I'd move, or I felt I would lose my balance and fall down.
Yeah, me too.
That eventually goes away. For me, it got better.
Mine has gotten worse as the Lupron has worn down. The last shot I had was a 2 month, so I just have the 1 month left. But it seems they've gotten worse towards the end of the regime, in the 6 months, than it was at the beginning. But yeah, so see me rubbing my arm or up here, it's just because I get stiff. And I'm assuming that's from the ADT and maybe residuals from radiation. I don't know, but it's minor compared to a lot of stuff. So I told my wife I would ask you guys because she was worried about it. But I do get a massage every night for my wife, so it's almost worth it.
The one thing to bear in mind, it's not so much the length of the shot you're getting each time, but the ADT itself is cumulative. So right. The longer you're on ADT, the more likely you are to experience some side effects, although at the same time, some people will experience less side effects or maybe grow more used to them. I'm not sure which. I never had a lot of stiffness, but I used to feel like a Mack truck had hit me when I woke up every morning. I mean, I just could not lift myself out of bed. And the one thing it did was really change my sleep patterns. And ever since then, it's been much harder for me to get up. And anybody else have any? Has anyone else had? I mean, pretty much everybody here has been on ADT. Not everyone, but most of you. Anyone else have these muscle issues from ADT to report?
I do, Rick.
Go ahead.
I've been on it 8 years, over 8 years now, and it definitely has a cumulative effect. And you do lose, waste muscle.
Right.
Yeah. This is Jim Ward. I've certainly experienced some of that, particularly in the legs. I think because you do lose some of that muscle mass, but at times, yeah, the legs feel like just like lead. But I find the more I move, the more I keep moving, the less I feel that.
Thank you, Jim.
We don't have to spend any more time on it, Rick. I just wanted to see if that was a common or noticeable side effect. And I'm on my, knock on wood, I hope I'm on my last 4 weeks of ADT. And then hopefully it's behind me, at least for a while. So, again, if that's the word right now, then I'm a lucky man. So appreciate your input, guys. I'm going to shut up now.
No, well, we'll see about that last part. I'm not so sure. But is there anyone else who wanted to add anything before I move on?
Yeah, Dennis.
Go ahead, Dennis.
When I see my doc, he always checks my ankles and calves for swelling. I suspect that's related to ADT. Do you have any swelling with the legs?
I do when I take amlodipine, which is a blood pressure medication that I use in a cocktail that is a mix to keep my blood pressure low. But I've dropped that down and still kept my blood pressure down by not taking amlodipine as much. I still do. But yes, I get stiffness and then some swelling. Not bad.
It's funny you mentioned that, Dennis, because talking to Peter Kafka earlier on in the week, he's been wrestling a lot with edema recently. And I said, well, I know a little bit about edema. I got a lot of edema when I was on hormone therapy. I mean, I went from being in the low 150s to about 170 pounds, and most of that was water weight and swelling. And it is a pretty well-known side effect. What you talk about with the swelling, I think other guys are probably, or what the doctor's doing is checking for swelling because he recognizes it is a side effect, even though it may not affect you per se. So.
Well, can I just add, Rick, that the more you exercise your legs, walking or whatever, you'll build the muscles down there that it's only the muscles in the lower extremities that move the fluid, move the blood and the fluid up to the heart. So, you want to make sure you keep active. That'll help.
Yeah, I walk every night with my wife and my dog, and typically by this time of year I've worked 50 baseball games as an umpire, and we're coming up on football season, if there is one, and I'm a football official too. So even the mile walk my wife and I take every night, it's nowhere near the activity that I had when I was healthy and the world was normal.
All right, we're going to go on to John Ivory. John, you are up. Speaking about baseball, you're up.
I will hopefully not swing and a miss. I'm also on Lupron. I've been on it for 5 months, along with abiraterone for 4. And I'm struggling with all the issues we were just discussing. I'm trying to run every couple days, and as my phone tells me, I run as fast as I used to walk, which is unfortunate. But my question tonight, I've got some moles forming on my back, and I did talk to my doc yesterday about it, and she said, to have them checked out because they're probably nothing, but it happens when it can happen when your hormones change a lot. Just wondering if anyone else has gotten extra moles and things from their ADT.
Wow, that's one that I don't ever remember us hearing that one before. Len, has anybody had any issues with skin lesions and moles, or very small skin carcinomas from ADT before? Anybody heard of that before?
She doesn't think they're carcinomas.
Okay.
Although she said that since she's not it's a real nuance that a skin doctor really needs to look at to tell. Okay. I'm hoping they're not carcinomas.
No, I hope so. Who's your, remind me, do you see Alicia Morgan's?
Yeah.
Right, that's what I thought.
I actually got to see her face to face yesterday for the first time in God knows how many months. Yeah.
Did you tell her you attend our group?
Well, I did. I told her because, and the whole reason I attended is because I follow her, and she spoke when you had the parent-child thing. So
great. So anybody got any input on this issue that John raises? Great issue.
Well, I feel very special now.
Well, you know, this is Jake, John. It's I never thought about it. I never associated it with Lupron, but yeah, I have a lot of skin tags. I've always had moles, but I've gotten a lot of skin tags. And I just never even thought that they were related. So it may very well be.
Okay. All right, John, if anybody who listens to this later has any input on this one, send us a note, info@ancan.org or rd@ancan.org, and we'll connect you with John Ivory. But I think that was a first, and we don't have a lot to contribute. Not even my friend Len. I can't even get him to speak up on this one.
I mean, they are age-related moles and skin tags. So I don't know how sudden all of these moles are coming of age on you, John. But you know, as we age, we all get these little brown moles that are harmless. Keratoses, I think they're called. I'm not sure.
Yeah, and that's possible that I just hadn't noticed it till now.
Okay. Anyone else before we move on to Jim Ward? Any last call on moles and skin tags? Okay. Jim Ward, what's on your mind?
Hey, guys. Well, guys, I think I can pose a pretty simple issue, but I just don't know how complicated the answers or input may be. But, you know, Rick knows this, that I was diagnosed with osteopenia toward the end of last year after a bone density scan. So I've kind of been kind of vexed by what to do to treat it. I originally had a bone health consult with at MD Anderson in April. That got postponed. So just a few weeks ago, I saw a doctor. I think she wasn't an oncologist, but she was in their bone health group. Kind of long story short, she saw me an hour after the scheduled time. She seemed rather impatient, distracted, if not even somewhat annoyed. And in the end, she just kind of summarily said, "Well, I'm going to prescribe you the oral, the pill bone strengthening agent." And then I remember from so many calls where people were talking in this group were talking more about the injectable variety that I just kind of asked, "Well, what about that?" And she said, "Well, she didn't offer a lot of pros or cons other than just saying she likes to start with the pills because they're cheaper and the insurance company is more likely to approve it." And so, Rick, I don't think I shared this with you because I've just learned this, but I kind of posed the question to Dr. Korn, my GU oncologist at MD Anderson, said, "Look, what do you think about this?" And he said, "Well, I'm going to check with my colleagues and I know just the people to talk to." And he responded in the last day or two and essentially said, "Well, colleagues don't really seem to have an opinion." and so the bone health doctor said, "Look, I'll prescribe either one. I'll prescribe you the Prolia if that's what you want." But there just didn't seem to be a lot of analysis or judgment in all of this, and so I'm just kind of frustrated. I just want to know what this group thinks about the pros and cons of one versus the other, and whether or not there's a consensus that maybe one is preferable to the other.
Well, I mean, I'll for the benefit of the group, I will repeat what I told you, which was that when I got diagnosed, I was borderline osteoporotic, minus 2.4 in the spine. And they did my bone density test right just after I got my first Lupron shot. And which is what they're all supposed to do, because we know that ADT can have an adverse impact on bone density. And so I was prescribed an infusion of Zometa, I think in the standard, whatever the standard amount is that's given to people that have bone mets. But I was prescribed it once a year. So over the period of 2 years plus that I got the ADT, I had 3 infusions, one at the beginning, one at the end of the first year, and one at the beginning of the second year. And I also changed my exercise schedule, and I got a really good result out of that. So my bone density in my spine fell from minus 2.4 to minus 0.9, if my memory serves me right, which was a really good improvement. I can't say if it was the different exercise I was doing or if it was the Zometa. The one thing I do know is that you retain much, much more of the Zometa than you do in the injectable form or in the pills, and that the pills are really a pain in the butt to take because you have to get up early and you have to fast, take a pill, and then you can't eat, and it's just a pain. So if it were me, I would be asking for an injectable form. Now, what you're looking at is denosumab as opposed to Zolendronic acid, and the Prolia is in a different dosage to the Xgeva, which a lot of the guys have gotten Xgeva. But for me, if I could get that, I would go personally for the injection. That's my own personal input. I would ask for the injection. Who else is there anyone else here that's osteoporotic, first of all?
For sure, I am osteopenic.
Okay.
And I had a bone scan sort of once I was it's almost going on a year ago since I was diagnosed. Immediately did a bone scan and came back osteopenic, which my good friend, the rheumatologist, said is not so unusual at my age. But they immediately put me on injectable and everyday calcium and vitamin D. So there's no question in the mind of my physician, and I wasn't going to argue with them, is let's treat this as aggressively as we can because we know that ADT is going to make it worse.
Right. Now,
so I would strongly urge.
What you said you're getting injectable? Are we talking Prolia, Xgeva? What are you getting?
I think it's Xgeva.
How often do you get it?
It's like every 3 months.
Oh, it could be.
I think the Prolia is every 6 months. I think,
it might be 6. I mean, the bottom line is I have to tell you, I don't pay that much attention if it's working. So, but but my own sense of it from reading the literature, again, and experiencing it, the injection is not a big deal, and it works. So I think it would be the way to go if it were me, and it is me.
Right.
Well, thank you for that.
Herb, have you had any side effects from that, or do you know from your reading if there are side effects?
I mean, I haven't, to be honest. The only side effects I've had, well, other than from chemo at the beginning, which were pretty dreadful, from being on ADT has been just a modest amount of weight gain. And that's it. I mean, and hot flashes. which are probably the most annoying part of all of this.
Right. Len, what thoughts do you have?
Yeah, I kind of agree with Herb that for convenience sake, you're better off with the injectables. And I think they work better. So Prolia is half the dose of Xgeva. They're both denosumab. Prolia is once every 6 months, and Xgeva they give every 3 months. So if you have bone mets, they usually give you Xgeva. Like me, I'm on Xgeva now. If you're just osteopenic or osteoporotic and you don't have bone mets, they might just put you on Prolia. It's lower dose and only once every 6 months.
Yeah. Well, that's kind of that's my situation. I don't have any bone mets identified. I'm osteopenic. And Len, I was going to ask. It seems like you were on the bone strengthening agent, and I for some reason I have this idea in my head that you were taking something. Maybe you were on a different injectable before Xgeva, but you were like telling the doctor, like, hey, squirt half of that out. I don't even want that much. Or am I just making that up?
No, it's you remember well. They were going to, they had set up an Xgeva injection. You know, it takes time to do this in the pharmacy. So they had the Xgeva injection ready to go. And I said, wait a minute, Dr. O said he wanted me to get Prolia, which is half the dose. So they checked with the pharmacy, and the pharmacy said, yeah, go ahead, just push out half of the dose. So they started me off on 6-month Prolia just to see if I had any untoward reaction. And I didn't. I had no reaction whatsoever. So after that 6-month period, I was switched to Xgeva.
I see. And did you have any side effects from the Prolia, or do you know what kind of side? I think we all know about this potential jaw necrosis, which seems like a very low risk. But what else is out there that?
I'm not too much aware of any other issues. Maybe some people complain of bone pain. I've never experienced that. How about you, Herb? Have you ever?
You're muted, start again.
When I started, I had actually jaw pain to begin with. And after doing a CT scan, they said it has nothing to do with the cancer. And over time, it's gone away. So, I went to my dentist, and and I talked to a whole bunch of people about this, and they basically said, well, it's likely inflammatory, so just take some anti-inflammatories, which I have not done, because even though I was a pharmacologist, and taking a zillion drugs now, I don't really like taking drugs. So I would say just the downside for me has been zilch, other than the nuisance of taking calcium and vitamin D every day.
Yeah, and I've been doing that from the very beginning. Yeah, unfortunately, they didn't do a bone density scan in the beginning, and even the Center of Excellence, MD Anderson, when they initially issued the results of the bone density scan, they said I was within the normal range. And those numbers are kind of hard to interpret when you're first confronted with them. You're like, well, wait a minute. So a bigger, like negative number, is that good or bad? Anyway, I came back to the report. Of course, when I got the report, I was like, oh, great, and I just kind of buzzed off to something else. But then I came back to it, and I just thought, I just want to read this again. And I read it, and I was like, wait a minute, this doesn't seem right. And so I sent a note to Paul Korn and said, this doesn't seem right to me. What do you think? And next thing you know, they're issuing an amended report, 2 months later saying, oh, you've got osteopenia. So this, they haven't hit, in my opinion, they haven't hit a home run in terms of, handling this osteopenia, which I realize is that's not the big elephant in the room. But anyway, so I guess what I'm hearing, I think I heard, especially from Len, is you think the injection just generally is more effective than the pills.
If it were me, I'd be asking for the Prolia. That's all I can say.
Well, it sounds like there's sounds like there's a consensus here. So that's what I'm going to push for. And I think, Rick, you made a good suggestion when you and I talked about this offline, but I mean, I don't know, what Len or Herb had to say about it, but Rick was kind of suggesting, if there is an issue with an insurance company approving it, maybe it would be more likely to be approved if the prescription were written by Dr. Korn, a GU oncologist, as opposed to somebody in some bone health group. I don't know. Thoughts on that? And then I'm done.
I agree with Rick.
Okay. And John Ivory, you had something you wanted to say?
Yeah, I was just wondering I've got osteopenia, and I'm not sure which doctor would prescribe it, but it sounds like the medical oncologist could take care of that.
Yeah, I would definitely. I mean, if you know you're osteopenic going into ADT, definitely raise it with Dr. M and ask her if you can get some bone strengthening agent. And, see what she says. My guess is she'll probably suggest Prolia as well.
Okay, great.
I mean, how serious is what's your T-score?
I don't remember, but I've been osteopenic for probably 7 or 8 years, and I did qualify as osteoporosis or product, or however you would say that, but it went down for some reason in between.
Okay, yeah, absolutely raise it with her, put it on her radar, and absolutely you should be taking some sort of a bone strengthening agent. What, I don't know, but I mean, I can just tell you that based on, it's anecdotal, but based on my experience and other people that I've known, you need something.
Great, thanks.
Okay.
Well, thanks, guys. I appreciate it.
We should probably mention to Jim that before you get either Prolia or denosumab, probably Prolia for you, check with your dentist, make sure you don't have any upcoming dental surgical procedures, because that could increase your odds of getting osteonecrosis.
Yeah, Len, I appreciate your. I appreciate you raising that. I'd heard that, and so I actually have a little bit of gum recession. So I had a couple of gum graft procedures that I did, sort of knowing that at some point I was going to be on a bone strengthener. But I really appreciate you flagging that.
And Jim, Carl, I know you're on the phone, so you cannot see it, but Carl Forman has suggested you look at the Xgeva website, xgeva.com, because it has some very good information.
Okay,
we'll do it. Thank you, guys. Really appreciate
it. Hey, Rick, one question on that.
Yes.
No one mentioned Reclast as an option.
Yeah. Reclast again is one of the same drugs. I think Reclast might be Zolendronic acid. So again, it's the same drug in a different format. Len or Herb, is Reclast Zolendronic acid?
I think so, or it's some kind of bisphosphonate like zolendronic acid.
Exactly. I'm sure it's a bisphosphonate, but if it's it may not be the exact same chemical composition.
Right. So yeah, I mean, again, it's definitely something to consider. Now, if I remember correctly, Reclast is also given in injectable form, is it not?
It is. I think so. Yes.
Yeah. So it is another option for John Ivory or for Jim. I mean, it's definitely another option. I mean, we do seem to think the trials have suggested that the denosumab is a better drug than the bisphosphonate, the various bisphosphonates. But again, I'm not a doc. I can't comment. I got Zolendronic acid. If it were today, I'd probably be asking for denosumab. But again, just talk it out with your doc. And I mean, if they say they're happy to give you a Reclast, and I wouldn't fight them. I mean, I don't think there's enough of a big difference. Len or Herb, do either of you want to comment on that?
I agree with, I think denosumab would be the way to go. But again, if you don't have metastatic disease, zolendronic acid may also work. I think, talk to your doc. I think this is where I think asking hard questions and making sure you get a good answer before you do anything would help.
Right. Agreed. Yeah.
Yeah, I agree with that as well. So is John Ivory, is John Ivory, who's seen Alicia Morgan's, who's going to talk about potential bone strengthening agents?
Yes.
Well, I'd love to hear what she recommends. I realize we're all in different situations, but I'd love to know.
I'll let you know if I don't talk to her before I've got an appointment in a month with her. So.
Thanks, John.
Thank you.
Dennis, are they giving you Reclast right now?
I had one dose of Reclast 2 years ago, and I'm due for another bone density in September.
Yeah, but I mean, you do have bone mets, do you not, Dennis?
No.
Oh, you don't. It's just lymphatic disease.
I was borderline osteopenia, osteoporosis 2 years.
Okay.
So I guess if I've improved, maybe I don't need to continue the bisphosphonate. I don't know.
But you only got one dose 2 years ago. You've got nothing. You're not taking Fosamax. Yeah, I think what's important from the discussion with Dennis, I think what's important is that if you do have an issue, you really should get tested each year. I mean, I know when I was monitored by Kaiser, they did order a bone scan for me, a bone density test every year to watch, and I think that's probably a good practice. Because you want to make sure that the ADT isn't, thinning your bones. And if you have a proclivity to that, as some of us do, we really need to be monitoring it. I know that the protocol is once every 3 years, I think 2 years or 3 years, but there's an exception if you're on ADT.
Okay, thanks.
All right, Herb, you have a question for us.
Well, yeah, I mean, now last week's numbers were reassuring in the sense that PSA sort of, stayed more or less the same. So it's now down to like the lowest it's been, which is 2.1. So that was reassuring. And so then I raised the question, about radiation, which I brought up with you again, and my oncologist said, yes, let's talk to the radiation oncologists to get started. So I want to hear from anybody who's done the various types of radiation, because there's so many different choices these days. People say, well, look, why don't you do proton therapy? And other people say, and so again, the literature doesn't help, because in terms of efficacy, it all seems about the same. So it's a matter of side effects and convenience. So I'm eager to hear feedback from any of you about, avenues to either look at and think about or research before we move ahead.
Okay, so let's just be specific. What we're talking about here is radiating the prostate gland, where Herb's prostate
radiating the prostate
has never been treated, and we're now talking about treating the primary. Is there anybody on the call who has been through treating the primary? I know one person. Okay, that one person can go. We have a bunch of them, but there's only one on the call right now. Oh, no, wait a minute. Dennis, I think Dennis treated the primary. Yeah, we have two. Yeah, go ahead, Len, and then Dennis.
Well, first, Herb, could you please remind me a brief history, like your Gleason and
Gleason was 5+4
okay.
and metastatic to more than oligo. So it's got quite a few mets, bone mets. And so history after that was first chemo with Taxol, which I went through 3 cycles, which lowered my PSA from 28 to 8. But also they just felt the side effects were too much. So said, let's switch you to abiraterone, which they did in January. So I've been on that for like now 7 months. And it went down even more. As I said, it's keeping down. And I said, now that we're in this hopefully stable situation, let's get rid of the primary. Is that
So
enough? Of you need more?
Sorry, you're on abiraterone and
Right.
Lupron or just abiraterone?
And Lupron and prednisone and calcium and denosumab.
Right. Okay. So the real guru on radiation is Alan Edel. We should put up his blog for in the chat box. So I had very high dose radiation therapy from Sloan Kettering. They're the only ones that go as high as they gave to me, which was 48 sessions, 86 gray IMRT, and they did my prostate and the whole pelvic girdle, which you should have done as well.
No, I'm sure that includes the pelvic girdle. It's not just ED.
So, another alternative is the SBRT, which the data looks like slightly better than IMRT and possibly a little bit lower side effects. You'll hear from proton beam guys that that's the greatest thing since sliced bread, but all the studies have shown that it's no more effective than IMRT or SBRT, and the side effects are about the same. So, and it's very expensive, and I'm not sure if some insurances cover it, some don't. SBRT, of course, is far fewer sessions.
Right.
Yeah. So, I mean,
there are also these hypofractionated protocols.
Yes, and they've been shown to be just as effective.
They work. They're just as effective. Right.
Yes. That for IMRT, yes, hypofractionated.
Right.
Like you can do just 28 sessions. I've heard maybe even 24.
So, any other, Rick, Len, that was great advice. So I'd like to look at that blog, but but the bottom line, it seems to be that there's more or less equal efficacy from everything. So it's just a matter of 47 sessions is a lot of sessions.
Yeah, well, that was 6 years ago. I wouldn't do it now.
Yeah, it's Dennis McGuire. I completed my treatments in April, and I had SBRT and 5 sessions.
Huh.
So I did have a quick response on the PSA, but I would say it's probably too early to tell, how durable the results are. But the side effects were very minimal.
I have a question. Don't you stereotactic guys have to get imaging in order to give them something to shoot at?
Yes, they must.
Yeah. It's actually, I had a pretty interesting machine that they used. It was MRI guided SBRT, and it was real time. So you didn't have to go into
Right.
a frame. They would MRI you every time, every session, and it would constantly take pictures. So if you happen to move, it would adjust the radiation. Or if the
So
prostate
Dennis,
were,
where did you have that done?
the University of Wisconsin Carbone Cancer Center.
So I have a question on that, Dennis. So they gave you an MRI before every session.
Yes.
In a tube. You went through the tube in every session. And then that MRI was then you came out of the tube for onto the radiation table, correct?
No, the machine is all integrated.
So you had your radiation in the tube.
Yes.
Wow.
Let me get you the name of the machine. I've got it, I think, right here.
Okay, that's really interesting. So the MRI machine and the radiation machine were integrated into one machine.
Yeah, exactly. So it's real time. So if it needs to make adjustments, if you happen to move, or if your prostate moves during the radiation session,
right,
or if your bladder is more full than the last time you had it, or less full, that can, alter where your prostate is.
Was it called a True Beam machine?
Say that again, Joel.
Was it called a True Beam machine?
True Beam.
For it.
I definitely have heard of True Beam. I mean, the only real time that I'm familiar with is the machine with the transponders, with the Calypso radiation, where the transponders are continually sending out a signal, and the machine is adjusting as it's getting the signal. But those are like the same type of transponders that you have in the car when you go through a toll booth, and it registers that you passed underneath. But Dennis will find that. Now, the one thing, Herb, that I want to point out in Dennis's situation was that was only radiation to the gland. So I don't believe that included the pelvic girdle.
Correct.
There is a way now to use stereotactic body radiation therapy for the pelvic girdle. Alan Edel looks at that in a blog post. And I think that the only place they're doing it is at Carbone, which is where Dennis got his treatment. If I remember correctly, Alan telling us about this and saying that, what was the name of your doc, Dennis, your radiation oncologist?
Dr. Floberg.
Yeah, I think he said Floberg I think he said that's the guy who's testing this SBRT for addressing a wider, more dispersed area like the pelvic girdle. I put Alan Edel's blog in there. Herb, if you want to talk to Alan directly, we can arrange that too.
Great. Yeah. I mean, the only decision would be, right now I'm officially part of clinical trials here at NIH. To go outside I'd have to see how that affects my eligibility for the trial.
Right. What equipment do they have? What equipment would they be using?
Well, that's what I don't know yet. That's where I'm going to have an appointment. I'm trying to get an appointment with the radiation oncologist to sort of discuss these things.
Okay. I do think, I mean, based on the men that we know that have had the gland treated, Dennis, Len, Ken Anderson. Who else has had? Who else can we think of that's had? John.
Gary's, I've had it, but I'm one of those that Len said didn't sound like it was as effective, but I had the pencil beam proton at Mayo Phoenix, and they did the prostate, they ablated the prostate and the prostate bed.
Right.
And I'm a proponent of it. I haven't had one side effect from it.
So
it was done in. It was
has
done
anybody
in.
had bad side effects?
It was done in December. We did 20 sessions, and I had a total of 50 GU.
Okay. Herb, you asked about side effects to somebody?
Well, I'm sorry?
What was your question about side effects?
My question was the side effects. I mean, right now, what I'm hearing from almost everybody is that nobody's had any really serious side effects.
Yeah, my only side effect was
And you had
a sense of urgency during the radiation period.
Which I have too.
Typically in the morning, but it wasn't severe.
Yeah.
So I found the name of the machine. It's Meridian View Ray machine.
Meridian View Ray. Okay, great. Thank you. Just in perfect timing, right on the money. Ken Anderson just joined us. Ken, we're talking about treating the primary gland for those of you who are metastatic, and Herb has been asking for experiences, and Dennis has spoken, Len has spoken, Jerry Pelfrey has spoken. What is your view on treating the primary as a metastatic patient?
First of all, sorry I'm late. I got stuck putting lights in with a kid on his Jeep, kind of longer than I anticipated. I would just say what Dennis stated. You know, the only problem I had while radiating my prostate was a sense of urgency from time to time. But other than that, it was pretty easily tolerated. They did the prostate versus doing radical prostatectomy, and they did the prostate bed. So no side effects. None. I must admit, Jerry Lucas has been doing it here in Phoenix at Arizona Oncology for almost 30 years, so he's pretty skilled at the bloody trick. So, but I think it's pretty well tolerated by most.
So,
and this is Jim Ward. I had a similar experience with Ken. I kind of echo a very similar experience.
That's great. I really appreciate this feedback.
Yeah, you've gotten about 5 or 6 guys there, so from the horse's mouth, so to speak. So
right, and I will keep, once we have that conversation, I'm going to be back here to talk about what they presented me with. So we'll see.
Excellent. And if you want to talk to any of these guys individually, shoot me an email and I'll connect you also with Alan Edel. Alan's blogs are pretty technical. He is, as Len said, he is really the lay expert on radiation, and so you'll find his stuff pretty good. Okay. Let's move on to Carl Forman.
Hello.
Hello.
Okay, I had to write down some of the items to make sure I'm going to cover everything. Just briefly, I was invited to become a member of a focus group in regards to Xgeva, sponsored by Amgen. So in about 2 weeks or so, I'm going to start participating in that. And if there's anything of interest, I'm glad to share that with the rest of the group. They were interested in finding the volunteers such as myself who are currently being treated or have been treated, and discussing possible side effects. So I was kind of scratching my head too, because like one or two other gentlemen here was saying, the only thing we're really aware of with side effects of Xgeva is possible jaw necrosis. So I don't know. I'll see what I might learn by doing that. Also, U.S. News just came out, I believe it was this morning, with their top 10 cancer hospitals. And if anybody was interested, MD Anderson was 1, Sloan Kettering 2, Mayo 3, Johns Hopkins 4, etc. So if you're interested, you can look at that. In regards to one of the discussion items earlier about leg tightness and edema, yes, I'm another person who's been dealing with that. And a doctor who I've been seeing, who's a physiatrist, I had mentioned to her, I said, I'm not walking as fast as I used to. And one of the few things I am doing during COVID-19 is walking around the neighborhood. As opposed to having been able to go previously 3 to 4 times a week to the gym, which I haven't been doing. I have been doing some online classes as well to kind of supplement it, but it's nowhere near as vigorous as what I was used to previously. She had said that with the pain in the legs, and I was also recently diagnosed with spinal stenosis, she thought it might be beneficial for me to have a consultation with a neurosurgeon. I said, oh, neurosurgeon, wow, okay. But she believes that there's a possibility that the leg pain and tightness could be emanating from the spine and some compression that could possibly be alleviated from a process with a neurosurgeon. Now, when I mentioned this to my oncologist, he said, no problem going to have a consultation with the neurosurgeon, but if they're going to start talking about surgery, you better talk to me first.
Can I just make a comment on that? And I think it is significant. And we do know people who have had spinal surgery with spinal mets. But the problem is this, that what the cancer does if it's in the spine is it eats away at the structure so that the bone doesn't have any integrity anymore. And it looks like it's solid, but then they start poking and it just crumbles. And so, it makes me very nervous when men start talking about spinal surgery and they have mets. And that's, again, not a medical opinion. It's just my own opinion. But you just bear it in mind. So you are on a roll. Keep going.
Yes, okay. And so absolutely tread very carefully on that item.
Yeah.
Finally, I just want to talk about, we all have experienced side effects from treatments and whatever. So the one I wanted to focus on now, because it seems to be the most annoying to me at the moment, is dealing with constipation and gas. And if anyone has any home remedies or suggestions as far as dealing with that particular side effect.
Where's my man, Jake? We're going to have to wake Jake up. Are you awake, Jake? I think not. Look.
No, I'm here. I'm here. Well, yeah, I'm not an expert on constipation. I do know that I had it for about a week and a half, and I was to the point I was impacted. I had to actually, too much information I know, but I actually had to pick turds out of my butt. They were impacted so much. I've been taking, when I get it, I take mineral oil at my wife's suggestion, and it does help. And my doctor, I mentioned it to my doctor, thinking it was a side effect of the chemo, and she suggested Colace, Colace.
Jake, I told you, prune juice.
Well, yeah,
prune juice. Prune juice right after you do chemo, and you won't have a problem.
I keep forgetting that, Ken, but you're right. Prune juice, I have not tried it, but I think I will.
It works. Pure and simple, it works. I know first.
How do you make it taste good? How do you make it taste good?
Oh, I let it get warm in the car for a couple hours and just drink it, and it tastes like crap, but it works. Boy, does it does work.
How much do you drink, Ken?
I don't know. I drink it out of the bottle. It's a big bottle. I just take a couple big jugs.
A couple of jugs of prune juice?
No, I just take a good couple guzzles.
Oh, okay, okay.
I don't know. It's probably a cup and a half or something like that. But I don't think it really matters. It'll just do a better job the more you drink.
Right. I mean, so I forgot to say, every day I take Metamucil, and it makes me into a regular guy.
Well, you're not doing chemo now.
So
Chemo definitely messes with your system. So I don't know if Metamucil would do it. But
Okay, I have a suggestion.
But I've got to leave because my wife says it's dinner time. So I'll see you next week.
Okay, all right, thank you. All right, now, whose wife has a suggestion? Oh, Joel's, go ahead, Joel.
I've been impacted twice where I didn't have a bowel movement for 7-8 days, and I had to go to the hospital. And the doctor recommended this, magnesium citrate. And within an hour, you're going. And the second doctor who saw me was sort of questioning why I was there. And he says, "Haven't you heard of magnesium citrate?" I said, "No, I never have." And so I went to buy a couple bottles, and I keep a couple bottles handy, but I've never had the problem since. So magnesium citrate was certainly, if you're impacted where you can't go at all, that'll certainly do the trick.
Is that commercially available, Joel?
Oh yeah, I got this from CBS. This is it's not that, I think it's $6-7 a bottle.
And how much of that do you drink?
The whole bottle. You drink the whole bottle, and you're going within an hour.
So don't take it before you go to a doctor's appointment.
No. The doctor says go home first and stay there before you drink it after you buy it.
I'm also scheduled for colonoscopy within the next 10 days, so I'm sure most of us have experienced that kind of a prep as well.
Yes. I don't want to even go there.
So just a final thing. I know that Peter's not on here and was watching the weather forecast that Hawaii was being hit with a hurricane. How is Peter?
Peter is fine. We asked him last night when he was moderating the low intermediate call, and he said it was all, excuse the pun, a storm in a teacup. It passed to the north. It passed beyond. It was supposed to hit this island, that island, the other island, but in fact, it passed completely to the north. So he was very relieved, and he's a happy camper, and he's doing okay other than this edema issue. So, which hopefully will resolve. And I will say that there are some of us who happen to like prune juice and prunes, and I'd be happy to take anybody's dose of prune juice at any time. So just saying. All right, Carl, have we covered everything for you?
Yes,
today?
thank you.
All right, good. You look like you're doing very well, by the way. You look good. You sound good.
Well, so far, yes, I'm trying to keep it out of my mind that I do have my next oncologist appointment is on Thursday. I had blood work yesterday, so I always get anxious to see what's going to be my next PSA number.
And by the way, we have another webinar in the talk series tomorrow night for ovarian cancer. We've got some interesting people, including one fellow who we've been supporting for 2 years in our caregivers group who lost his wife in February with his 2 kids. We've got an outstanding moderator, the co-leader of the UCSF Center for BRCA Research, Pam Munster. I'm mentioning it to you, Carl, because you might just want to watch just to see, to see Pam Munster to get a sense of her. She's very She's probably one of the leading oncologists in the country when it comes to BRCA. She's BRCA positive herself, and she's had a double mastectomy. I don't know about a oophorectomy. She has 2 daughters, but she's quite special.
So hopefully the Zoom will allow more than 100 participants.
Don't even go there. Let me just say on that subject that it's not on Zoom. It's going to be on GoToWebinar. And we have the best volunteers, including Jake. God bless him, because Jake is actually the lead for the GoToWebinar. So, Jake, how are you feeling about tomorrow night?
Man, you're keeping me awake tonight, Rick. I'm a little bit nervous, to be honest. I saw what happened with the Zoom meeting a couple of weeks ago, and I feel the pressure, to be honest. I'm afraid something will go wrong, and it probably will, but I'm hoping not. So I'm nervous about it, but I think we're going to do okay. We're up to 90 people, by the way. And Carl and anybody else who's interested, I'm going to put the registration link in the chat box. So if you know of anyone who has ovarian cancer or would be interested in listening, please do so. You can register at the link I'm going to put in the box right now.
Right. And whilst we're on this topic, we have over 400 people registered for Peter Carroll on Thursday night, who's going to be talking about the history and the future of active surveillance. I know that's not a topic that any of you are that much interested in. At the same time, if you've never heard Peter speak, he is an excellent presenter. I mean, he is probably amongst the top half dozen urologists in the country, and very, very open-minded to all kinds of treatment, promotes active surveillance, promotes speaking to a radiologist if you're coming in to see him about surgery. Just a very, very open-minded doc. And he was the vice chancellor at UCSF, and he was the head of the department. He recently stepped down, but he's worth listening to. But you may, if you don't register for that, you may get shut out, because we're well over 400 at this point, and the room only holds 500. So I just want to give you a heads up. But again, more important, I just want to say that Jake and Joe Gallo and the guys that are helping them, Peter Monaco and Rich Jackson, they have, well, Peter's on the call. So Peter, God bless you too. I mean, you guys are just been fantastic, absolutely fantastic. Thank you so much.
My pleasure to help, Rick.
Yeah, mine too, Rick. By the way, the Peter Carroll call on Thursday has 426 people already registered. The limit is 500. So, just jump in now while you still have a chance. And don't forget tomorrow night if you know of anyone with ovarian cancer.
Right. Okay, let's keep moving along, and it's Scott Hogan who's up next. Scott, remind the guys about your situation, because I know one of us at least forgot on this call.
Oh man, I don't know where to begin. I'm on the abiraterone and prednisone and Lupron routine. Have been on that since March. I had one comment and one question. My comment is, for constipation, I recommend Aunt Jemima pancakes. I can go deeper into that. Why Aunt Jemima? And I hope that name does not disappear. And second, does anybody have experience with the artificial sphincter?
We have had men, we've had 2 men who had an artificial sphincter. Sadly, neither of them are with us anymore. One was my co-founder, Rob Beniscus. And the other was Who was the other one?
I think his name was Jim.
Jim, yes, thank you. It was Jim Harrington.
Right, right.
Well, I hope there's not a correlation between having an artificial sphincter and passing away.
I don't think there's any relationship there. No.
God, I hope not.
I know that Rob was as a result of a radical prostatectomy, that he never regained good continence after his radical.
I'm sorry, and Jim said it was from his radiation. He had I don't know if his radiation was post-surgery or salvage or whatever. I really don't remember, but I know he said the radiation caused the problem. And he could never get it back.
So, Len, what are your thoughts on artificial sphincters? And Scott, probably before Len responds, tell us why you're asking.
Well, the two big side effects of the radical prostatectomy, most of you guys, if you've had it, you know, but one of the big side effects is incontinence. And I've tried everything, you know, Kegels, all this other, and I'm making somebody rich because I'm buying all these pads, and I figure, you know, it's a little hard during work when you got to change your pad. And I've had some bizarre, actually sometimes funny stories. So anyway, I looked into the artificial sphincter. I've had one procedure you have to qualify for it. And I'm gonna tell you, that's why I'm asking you guys, and you're all probably sitting there, no problem, I could do it. You don't want to do this procedure. And then there's another procedure called a documentary thing. I mean, it's rough. So I'm just wondering if anybody had experience with it. I guess if we can't talk about that, my only question is the abiraterone and the Lupron. It does make you tired. And it's last Sunday, I nearly threw up taking that abiraterone. It's like, oh my God, it just 4 pills. It's a lot.
But let's stick with one thing at a time here. Let's stick with the artificial sphincter. Len, can you think of anyone else other than Jim Harrington and Rob who had an artificial sphincter?
You know, I believe there was a guy at Ann's place who had the artificial sphincter, and it worked for him. This was several years ago, so details are fuzzy. But other than that, I really don't know much about it, Rick.
Well, I also can tell you that I know that both for Jim Harrington and for Rob, they were very happy with the results. I seem to recall that there was a button in the scrotum or somewhere like that they were able to activate with. What I would suggest is a couple of things. Have you posted on Inspire about for anybody that has an artificial sphincter?
No, posted on which, please?
Inspire. So Inspire is a written forum. You want to go to the prostate cancer forum, which is sponsored by us too. And you can ask anybody on there. That is one. Another one that we don't often talk about because most of us have been banned from it is Health Unlocked. We like to call it Health Locked Out at ANCAN. But Health Unlocked has a large number of people. You can go to Health Unlocked. You can look and see and post on there. And then there's one other group that has a good written forum. I'll tell you what they're called momentarily. It's just gone out of my mind right now. PCA. Healing Well. Healing Well has a Healing Well. I can put that link for you in the, I'll put that link for you in the chat window. And Jake already put, the Inspire connection for you in the chat window.
Excellent. Thank you.
Thank
you, Jake.
So,
Scott,
go ahead, John.
you failed physical. You're thinking of surgery.
I'm sorry, I can't hear him.
Yeah, you're cutting in and out, John. Try shutting your video, because it looks like you got bandwidth problems there. See if that helps. If we can hear you better, if you turn your video off. Okay, try again now.
I assume you failed physical therapy if you're thinking of more drastic solutions. I've heard a number of guys say physical therapy them a lot, and I'm pretty incontinent, about 4 or 5 months out from surgery, and I'm going to physical therapy actually tomorrow. But the guys have said it's helpful.
The physical therapist was worthless and charged $340 an hour. And after 5 sessions, it was pretty clear it was going nowhere.
Okay, can I ask you a question? Was she a pelvic girdle? Was she a pelvic floor physical therapist? Did she specialize in pelvic floor?
Let's see, how do I put this? In all of Phoenix, if you ever come up here, Rick, there's only one. It's that I can't think of their name, but it's one medical group that does the. I can't think of her actual name, but your question is a great question. I wish I had an immediate answer, but there's only one person who does that kind of thing. Spooner Physical Therapy, and she's way over in Glendale. I am not kidding you. One person.
Okay, again, I would say it's not convenient, but it's better than going through the surgery of having an artificial sphincter. If you can have success with her, and maybe she can do telehealth. Maybe she'll do telehealth with you right now.
No, I mean, I went there for over a month and a half. It had no effect.
It had no effect.
Yeah.
Okay.
So I don't know. Maybe I can try going back. Who knows?
Well, I just want to suggest if you do go back, it sounds like you've got the right person, but it should be somebody who specializes in pelvic floor physical therapy.
Okay. Thank you.
Anybody else have any other suggestions for Scott on this issue?
There was a gentleman locally that was on this call a couple of times, but it's been about a year ago that he had that done several years ago, and he was very satisfied with it.
Okay. And Joel Blanchette has suggested Dr. Leach at Tower Urology, who Peter Kafka has seen. Peter Kafka knows him. It's in the chat window again, if you open the chat window. So, and he is a favorite of PCRI. That is true. I'll look after the meeting and see if there's anybody else I can see from memory that we've had here that's had an artificial sphincter that you could talk to. I just don't think, I cannot think of anyone else though, Scott. Let's talk about your second issue, which is difficulty taking the abiraterone pills. There's a bunch of you that have taken abiraterone. Can you give any thoughts or suggestions to Scott?
Well, I remember when I took it, I did have slight nausea. I think it's a fairly common side effect of abiraterone, Scott. I guess you just have to deal with it. Yeah, and the pills are a little bit difficult to swallow.
Yes.
I've had worse. I mean, some calcium pills make me gag, but abiraterone is getting close to that.
Len, weren't you on the abiraterone and then it didn't work, and then It
No.
affected your liver?
No, it worked. I just wasn't, I felt like it was making me physically fatigued and cognitively damaged, whatever term you want to use. So I asked my doctor to switch me to darolutamide, which he did, and it's much better for me.
I've been cognitively damaged for a long time, so it doesn't have that much effect. I voted for Trump. Oh dear.
We have a few people who are in your boat, but I'm not going to pick on anybody that's on this call right now. So you're all safe. Don't worry. Who else has done abiraterone on the call? Carl.
Yes, I was on it for 6 months before it failed, but while I was on it, I did have some nausea, and my doctor prescribed me with a medication. I don't recall the name of it, but there is specifically for cancer patients, there's an anti-nausea medication, which helped me greatly.
Len, isn't that the one that I always forget that begins with a Z? Is that,
Yeah, Zofran, ondansetron is the generic name. It's generic now. Ondansetron, yeah. I can put it in the chat box.
There's also
I bet it
granisetron.
was granisetron if it was for cancer.
That's the one. I take that myself.
Okay, so slowly, let's get them one at a time. Ondansetron, which was also called what, Len?
I thought the trade name was Zofran. I'm not.
Zofran, correct.
Zofran, yeah.
So ondansetron is one, and then the other one that John and Jake are talking about. Jake, go ahead. What's it called?
It's granisetron. I may not be the right way to pronounce it. G-R-A-N. Hang on, let me get my package again. G-R-A-N-I-S-E-T-R-O-N hydrochloride. And there was a brand name for it, but I think they stopped manufacturing it, so you can only get a generic.
Right, used to be called Kytro.
That's the one. Yes, thank you.
Thank you, John.
And Scott, I have a comment on the pills, swallowing the pills. Are you having a problem swallowing?
Yeah, I used to do 2 at a time. Now I just do 1 because they're kind of big.
They are big. Yeah, I took them for a few months also. What I found was I put the pill in my mouth and take a sip of water and kind of swoosh it around and then swallow the whole mess. That helped me.
All 4?
No. I was doing 2 at a time, but
Okay.
but just taking some water and swooshing it around, you kind of lubricate the works, I guess is probably the best term, and that helped me.
Dennis Correa, you have been taking these things forever and a day. What's your trick?
Yeah, I tend to have, maybe it's psychological, I think, of swallowing these things. And mine goes back to when I was taking this big calcium pill, like I think Len mentioned. And one day I went to try to swallow that thing, and it got stuck. It stuck in the esophagus, and I drank water, couldn't get the thing to dissolve or move. We finally called a rescue squad, and they showed up at the house, and I said, I can breathe fine, I just can't get this thing to dissolve and go down. And so we just kept drinking more water. Finally it went down, but it was scary. So now with the abiraterone, I try to drink a little water first, so you're lubricated. So because you're doing, first thing you get up in the morning, this is what you're doing. And it could be dried out from overnight. So take a little sip of water, get it down, but make sure you've got a good 10-ounce glass of water. And I like to do it at room temperature, because you can guzzle pretty good water at room temperature rather than if it's really ice cold. And so then I put the thing on my back of my tongue and take a little sip of water, not a bunch of it, because if I try to take a big guzzle all at once, the thing just floats around up there in my mouth, it feels like. I'll take just a little bit of water, and I'm thinking that I'm eating, and this is a piece of food. And so I just swallow it, and then immediately, so I've still got the glass up to my mouth after I take that initial swallow before the thing gets all the way down. Then I follow it up with the water, with a couple of good guzzles of water. And that's works for me most of the time.
Thank you. I think Rick likes that story.
Which one?
What Dennis was just saying. It was great.
Yeah.
You know what I've always find helpful swallowing large pills is a little applesauce. That really slides it right down. And I know you're supposed to be fasting, taking the Zytiga, but it's only if it's a fatty meal because the fat helps it get absorbed. But so if you take just a little bit of applesauce, I think it'll slide right down, and you don't have to worry about the fact that it's not exactly fasting, but for practical purposes, it is.
Len, how about prune juice?
What I ended up doing with my calcium thing was crushing it up, because that one I could crush it, and I mixed it with applesauce, and it went right down.
Yeah.
But when I talked to Humana, where I get the abiraterone, the first nurse I talked to was not familiar. She couldn't even pronounce the name of it. She said, "Oh, put it in a little gelatin, and that'll make it slippery. You can slide it down." And I said, "Well, the data said you can't take it with any food." So, oh well, then that won't work. So,
As long as there's no fat,
yeah,
like in applesauce, that's fine.
Yeah, I think you can take. I think Len's right. I think it's the fat content. John Ivory, you aren't you taking abiraterone right now?
Yeah, and it's funny because my grandmother used to take a lot of pills, and she said she just threw them in her mouth and took a huge thing of water, and that's what I've done ever since. So maybe it's a psychology thing, but I take a little water, I throw the 4 pills in, and then I try to drink 8 or 10 ounces right away. But doesn't sound like that's going to be helpful to the other folks on the call.
All right, Scott, we've given you a few suggestions here. Certainly I think we're doing better on the abiraterone pills than we are on the artificial sphincter. I do want to say on the artificial sphincter, I'd like you to think about joining Peter's call, which is on the 2nd and 4th Mondays of every month, the 2nd and 4th Mondays. If you go on our website, you can sign up for the low risk call. The reason I say that is because there's a lot more experience on that call with incontinence. It isn't a subject that we deal with as frequently. We do deal with it, but not as frequently. We don't have the expertise. Peter himself, I don't know that he had incontinence issues. He certainly had to catheterize for a long time before he had his radical prostatectomy. So, but there are plenty of people that have had experience with incontinence over a long period of time. I have a good friend who had a real rough time with incontinence and finally got some relief from electrostimulated acupuncture, which is a treatment that UCSF uses. One of the urologists at UCSF, one of the other vice chairman, other than Peter Carroll, gives that treatment. I think I may have a link to the procedure, but it actually worked very well. And it was his feet. The points were in his feet. So the acupuncture points that were treated were in the feet. So I can't tell you why. I don't know much more than that, but I do recall that. I will look and see what else I can. If I find anything else, I'll send it through to you. But have you talked to your urologist? Have you gone back to the urologist and asked him?
No, I moved on to a GU Med oncologist, and I should say the urologist. Yes, he's a urologist, but he specializes in these artificial sphincters. Yeah, I'm sorry. He is a urologist. Yes.
So, I mean, well, the reason I'm saying that is as far as your prostate cancer is concerned, you're in the right place with the GU Med-Onc. But as far as the incontinence is concerned, you need to go back to the urologist because that's not really the field of the medical oncologist.
Yes.
So you might want to go back to him and say you're still having issues and see if there's an in-between stage. I mean, whoever's doing this testing for you for the artificial sphincter, is that the urologist?
Yes.
And does he have any suggestions short of an artificial sphincter?
No.
You might want to get a second opinion. I mean, ask around in Phoenix and see who's good with incontinence issues, and see if you can get a second opinion.
That's an excellent idea.
And just see if there's an in between, because I do know as an in between that this electrostimulation works for many people. And I know I've got to keep an eye on the chat window, because if I've got time or someone else is talking, I know I've got it bookmarked. If not, I'll send it to you afterwards. Let's keep going. We've got 5 minutes and 2 men, so I think we're going to go over 3 men. Sorry, we got John, Joel, and Nazir still to visit. So just a heads up that we're going to be going over. All right, John. Antonelli, you're up. John A., are you there? All right, we'll come back to John. We'll go to Joel, and then we'll come back to John. Joel.
Okay, last week I attended a Zoom meeting with Susan Jacobstein, who is the US2 leader in Suburban Hospital in Bethesda, Maryland. And it was her last session, and she'd been doing it for 25 years.
Wow.
And during the session, it came up that people started talking about green light of the sphincter, or where after you had a prostatectomy, where the junction between the urethra and the bladder. And I've been getting up at night 5, 6, sometimes 7 times to urinate. And they were mentioning a couple of guys. Matter of fact, one guy said he had a friend who had just had the green light procedure that day on the sphincter. And I said, well, I know about green light for TERPs, but I didn't realize they offered a green light treatment for the sphincter. I sort of have the opposite problem of incontinence. I just can't void completely. So has anybody ever heard of green light for the sphincter to open it up? Or has anybody had the procedure before?
So again, this is not something we deal with often on this call. It's really something that gets dealt with a lot more on the low and intermediate risk call, where they do spend time talking about BPH, and also on the active surveillance call. There is one of the moderators of the active surveillance call has had a green light procedure for BPH, which is, I think, what you're talking about to open it up. It's an alternative to doing a TERP, correct?
Well, a TERP is done on the prostate, so that so your urethra is not squeezed down by the prostate, but this is further up at the junction after you had a prostatectomy, by the junction between the urethra and the bladder.
But the purpose again is to help you void, correct?
Correct.
So I don't know. I don't know where his green light procedure was. I know that it was to help him void, and I can definitely put you in touch. His name is Mark Lichty, I was going to try and put his name. I'll make a note to connect you to Mark Lichty and Joel afterwards. I'm afraid it's just not something I have much experience with. Does anybody else on the call have experience with that?
That's the question I have is, have you tried Flomax?
Yeah, I tried Flomax before my prostate was taken out 10 years ago. It did nothing for me back then. But I haven't tried.
Oh, go ahead.
No, I said I haven't tried Flomax since. No.
So using the link that Jake put in the chat box for Inspire, two things. I searched for green light procedure. There's 154, 158 hits. And I put in artificial urinary sphincter, the 182 posts. So you guys should check that out.
Thank you.
Thanks, Len. And I will, let me just put in for you right now. Let me put Lichty's email. So so it's M. Lichty, I'll spell it for you. Do you have a pen there or do I need to put it in the box, Joel?
Go ahead. I'm ready.
Okay, it's M-L-I-C-H-T-Y, M. Lichty, M-L-I-C-H-T-Y, at P as in Peter, T as in Tommy, D as in David, ptd.net.
Got it.
Okay, and again, send him a note, tell him the recommendation came from us, from Len and myself, that you're a regular on our group and that you'd like to talk to him about green light laser. Okay, he's also one of the principals of ASPE. Oh, if you tune in on Thursday night, you'll see him. He's going to be one of the people questioning Peter Carroll.
Okay, thank you.
Okay, so I think he would be the best resource. And like I say, you feel free to join the low and intermediate or the active surveillance groups and raise it in those groups, because you'll probably get very good feedback. And definitely both of you, both Scott and Joel, go check out Inspire, because you'll find a lot of information as Len has suggested. Anything else, Joel?
No, that's it. Thank you, Rick.
Thank you. I hope the lady, that group is now being passed into good hands.
Matter of fact, there's no new leader for it yet.
Oh my goodness. It's a little far from Len. Otherwise we'd volunteer Len. Len's an expert at taking over people's groups and running them. He just closed his picture. So he closed his video a second ago, so I can't see him. But Len's taken over the group in Danbury, and he's taking over the group down in Sarasota. So he's lucky he doesn't have a house in Northern Virginia, I would say.
Well, Jake is pretty close, and so is Herbert.
Okay, well, Herb isn't around, and Jake might do it, but only if he could do it on a telly basis. We'd have to bring Jake in on a telly basis. That's the only way you'll convince him to do it. Listen, you're the man. You're a leader. You're an us2 leader. Just what you need, another group.
That's right. Or it's all on Zoom anyway, so it doesn't matter where they're from, so they can join my group anytime. Yes.
Right. Exactly. All right. So let's finish up. Well, let me say, Ken Anderson, I'm going to Nazir next, but after Nazir, would you like us to stop by you?
No, I'm good for now. Thanks.
Okay. Are you? Is your head in a better place than it was when I talked to you earlier this morning?
Yes, it is. Thank you very much.
Okay, good. Then we won't make you talk to all of us today. Nazir, you need to unmute and tell us what's on your mind.
Yes, I just have a few questions. I was on chemotherapy before, a couple of years ago, And if I go on chemotherapy, the cycle is 21 days. If I was to take every week, with that, when I was on this 21-day cycle, the first week was very bad for me. I had to spend a whole week in bed because of the side effects. Now, going every week, will that be less stressful on the body?
You, you joined us a little late today, and we spent a long time speaking exactly about this with Jake.
But you did not talk about a weekly dose.
Yes, we talked exactly about a weekly dose. So a couple of things. One is when we post the recording, please listen, because we probably spent the first 20 minutes talking about weekly dose. Secondly, Jake, is there anything, Jake, you'd like to say to Nazir? He's asleep again, and I'm waking him up.
Man, you guys are brutal tonight. I'm sorry, I did miss Nazir's question.
Nazir wants to know, he missed the conversation we had with you at the beginning, but he's concerned about going back on chemotherapy on a 3 weekly dose, and he wants to know about the weekly dose.
Oh,
now Jake,
okay.
I thought Rick was joking when he said you were sleeping. Were you actually sleeping?
No, I actually wasn't. I was doing something else. I was listening but playing a game, and I kind of I just missed it.
All right. Just checking.
Thanks for keeping me honest, Ken. Nazir, first of all, I'll put the link to our YouTube channel so you can listen to the whole thing. It'll show up probably later on tonight or tomorrow, so you can actually listen. It's near the very beginning of the recording. But basically, they decided to do the 1 week thing with me because even though I'm a big, tall guy, I'm a little bit frail, and she was concerned about the side effects. So she decided to do the weekly thing, which is a little bit less each week, but essentially the same dose over a 3 week period. Does that help? Does that answer your question?
What about the side effect on the weekly one? Did you have a couple of days of side effects? Or not? Or none at all?
Well, no, I'm not going to say none at all. The day of the infusion, I have one coming tomorrow. She gives me a cocktail ahead of time of different drugs. She gives me an anti-nausea drug. She gives me dexamethasone and something else. I forget what. And I feel very good after the transfusion that night because of the dexamethasone. Rick makes fun of me because I talk too much when I'm on it. But the next day and for a few days after that, especially the weekends for me, is when I have the most side effects. But they're not bad. They're tolerable. Like I said earlier, 1 week, I've only been on this for 3 weeks. Tomorrow is my second start, my second round starting tomorrow. One time I had diarrhea. And we talked about, we put in the chat box a couple pills you can take for diarrhea. Then the following week I had constipation, and several people had a lot of suggestions for that. Prune juice being Ken Anderson's favorite go-to, and then somebody said magnesium citrate and colace. There's a lot of different things you can take for it, but they all pass eventually. Other than those side effects, I don't really have any so far. But unfortunately, it is cumulative.
Well, then it's better than taking the 3 week cycle.
Well, it depends. The standard of care is every 3 weeks. Doing it weekly is, like I said, you get a smaller dose each time. Cumulatively, it's actually a little bit more. 3 weekly doses, I end up getting a little bit more, and the amount they give you is based on your height and your weight. They do an M-square, some kind of formula that Len or Herb will be able to speak to better than me. But yeah, there's a formula that they use, based on your height and weight.
Okay, thank you. And now to Len. I have a question. You were going to write to Foundation 1. Did you write to Foundation 1?
Oh yeah, Rick and I were a little puzzled by that. What was it you thought I was asking them about?
Yes, about PARP inhibitors.
But what for what mutation?
Oh, you didn't discuss anything about any mutation. You said you were going to write to them and you were going to ask them, and you sent my documentation to them.
No, I don't think so.
No.
That's an email you sent. That you sent. Have a look at the email. That's from Rick. The email was from Rick, and your comments were in there.
Okay, we'll have to take another look at it. Sorry, Nazir, I don't recall that at all. Apparently, Rick doesn't either.
Yes.
But we'll check it out, and we'll have to get back to you next week.
I think the only thing I can think of, Nazir, was we might have talked to you about check 2, and because you had check 2. Check 2 shows up for you.
Yes.
And I think what we said was that we were going to, I don't know if this is the conversation you're thinking about, but we were going to write to Foundation 1, a Foundation Medicine, about how they determine whether these mutations are actionable. So, because we questioned whether certain mutations were truly actionable for prostate cancer.
Mm-hmm.
And CHEK2 is one of those mutations where it is in the pathway, but there isn't much evidence that PARP inhibitors will be effective. And we're continuing that discussion with them, specifically with relationship to ATM. But I think if we look at your, and I think I have your Foundation Medicine report, I think what you'll find is that it says that it's not actionable for prostate cancer, but it's actionable for, it has been found to be effective for other cancers.
Interesting.
Well, take a look at your report.
Yes.
Okay, that's the starting point. Take a look at your report. Let me see if I can pull it up very, very quickly, and see in your report. I mean, I know this was the situation with Jake because Jake had a mutation for ATM, and when we looked into it more carefully, what we saw was that Foundation Medicine says it's actionable for certain cancers, but it's not been found actionable in prostate cancer. And let me just see if I have your, yes, Nazir's, this is it. Okay, so I'm just opening your report right now. And no, for yours, it says for CHEK2, it says that olaparib and rucaparib are effective for CHEK2. So Len, does that ring a bell for you?
No, in the studies that I was looking at, CHEK2, along with a bunch of other mutations that, as you say, were in the HRR pathway, had very poor responses, like on the order of less than 5% response rates.
Well, I will send you. I'll send you Nazir's. I'll send you Nazir's report, and it does say here because I'm looking at it right now. Nazir, may I share my screen with your report?
Please do.
Okay, so hold hold on a second and let me. Okay, can you see it, Len? I'm going to blow it up. Hold on a minute.
Yes, I can.
I want to try and get it bigger. I don't know if that's, I think, the biggest. Oh, wait a minute. No. There we go. Okay. Okay. Len, can you read that?
Yes, I can.
So what that's saying is that for check 2, therapies with clinical benefit in patients tumor type olaparib, rucaparib.
Yes.
And 1, let's see what the footnote 1 is. Footnote 1, footnote 1, footnote 1. That was a beta. The guy, what's it? Wasim Abida in at Memorial Sloan Kettering, right, Len?
Yes, yes, he is. And I remember that study mostly focusing on ATM, where he said there was no evidence of efficacy for the PARP inhibitors for ATM. I don't recall it being about check 2, but I'd have to look at it again, Rick. And now's not the time to do it. We should, spend a little time so we have a better answer for Nazir next week.
Okay. So
before you close this
yes,
shared screen, on page 7, if you go to page 7,
yeah,
this is coming up.
Hold on a minute. Page 7.
Yes, all of these trials, or whatever you call them, are saying that the PARP inhibitors are included. Here you are. Yes, the first, second, they start from the third one, and they do mention the study of olaparib and other stuff. Yes. So basically, what I understand from the 4 doctors that I've been talking to, and they are saying that none of these will do.
I'm sorry, what do you mean none of these will do? And none of these are suitable for you? Is that what they're saying?
Yes, because not suitable for me. Why are they saying that? They think it will not work. That's what they said. When I pressed them a little more and asked them a question.
Okay. So let me ask you 2 questions. Let me ask you a question. Are they saying that you are not eligible for these trials, or are they saying they don't think it will work for you?
No, it's not the eligibility. What they're saying is these trials may not work for you.
Well, I think they're saying that for the same reason we're saying it, that there isn't much evidence that olaparib, any of the PARP inhibitors, have been successful for check 2. This is an issue for us. It's an issue that Len and I, and I'm at fault here because I've been so busy I haven't had time to look at Len's research. But we are arguing with Foundation Medicine as to whether they should consider check 2 to be, or ATM to be, actionable. We don't think they are. And the problem is they put something like this in the report, and then you as a patient think, this is a resource for me. Now, your doctors would tend to agree with us. They don't think that it's going to be much use to you. If you had a BRCA mutation, I think they would be pushing you into it.
Yes, and that means you're saying that Keytruda would not work for me also.
No, that's a different issue. The Keytruda is related to a different measure.
Yes.
These studies are looking at combinations of
yes.
pembrolizumab or niraparib with PARP inhibitors. And the reason why we don't think that you are going to respond to a PARP inhibitor is because back up here, your MSI status is undetermined. We know you need to be MSI high. Now that you could be MSI high, but they can't tell from your blood sample. They would need a solid tumor sample for that.
Yes. But they don't want to take a tumor sample from my lymph nodes because of the location and the size.
Right. So, you know, either we have to wait until you have a larger, another metastatic site, which is safer. You know, you could reach out to David Marshak and see if doing a second blood sample is going to make you more likely to be responsive to get a result. But I don't know. The problem that we're faced with for you is that CHEK2, you know, this is the good and the bad of running. It's a good discussion. It considers the good and the bad of running these tests. But if the company that is making these tests suggests that something is actionable, it sort of gives false hope. And we're not convinced it's actionable. Len and I are not convinced that it's actionable. That's why we're trying to take this on with them so they don't do what is happening to you, where you have hope that you think that the PARP inhibitor is an alternative. We don't think so, your doctors don't think so, but Foundation Medicine says it is.
Okay. So basically what you're saying, you're telling me that yourself and the doctors, the only alternative I have is chemotherapy. What happens after chemotherapy? I have nothing else to fall back on.
I don't think you should be asking that question. Because we don't know. We don't know what's after chemotherapy. There may be things after chemotherapy. There are these, Len, what are those things called? The like the
Bite.
Regeneron and the Amgen.
Bispecific T-cell enhancer.
Right, bispecific T-cell enhancer. Now, I'm not going to explain that to you now. I got another meeting starting in this room in 9 minutes.
Okay, go ahead, please.
But what I can say to you is the mindset of, well, if I do this, what about what's next? You've got to stay in the moment. Look, I'm going to read you what Lao Tzu says. Laotzu. He probably came from some place close to where you were born. Lao Tzu says, if you're depressed, you are living in the past. If you are anxious, you are living in the future. If you are at peace, you're living in the present. Right?
Thank you.
Let's not think about, well, what's next after this? Everybody is saying to you, Nazir, let's try some type of chemo right now.
Yes.
Because we think that's going to be easiest on your body and because you responded well to that last time.
Yes.
And yes, we can try and get you into a trial, but these trials with niraparib and pembrolizumab combined with PARP, they are going to be very, very, very tough on an 84-year-old man. 83-year-old man, forgive me.
84.
Len, do you want to add something to this?
Well, I mean, I agree with you, what you just said. I mean, the docs are saying chemo. I think that's probably your best option right now, Nasir.
Yes.
And it sounds from Jake's experience that, you know, following his lower dose schedule might be less toxic and you might tolerate it better. And Jake is responding. So I think that's a good path for you to follow.
Okay, thank you very much. I shall do that.
And you know, Jake is not taking prednisone during the week. He's just getting dexamethasone right at the time, and he's getting a smaller dose of dexamethasone at the time.
Yes.
Which is important for you because you responded badly to the steroids.
I know I did, yes.
So if we give you a lot less steroids, that's a possibility that might work for you.
Thank you.
Okay, but we'll keep pushing through. I'm going to send your report to Len as soon as we get done here.
All right, thank you very much.
In fact, oh no, I've got to close the room because otherwise the recording doesn't stop. Okay, so I'm closing the room right now. Guys, see you next week. We got another meeting starting in 5 minutes. Goodbye for now. See you next week. Bye.
Goodbye. Goodbye.
Bye-bye.